All right, I'm going to go ahead and get started. People may still be joining in, but in order to respect everybody's time and the 1 hour hard stop that we have for the Zoom link, I'm going to go ahead and get started. I'd like to welcome everybody to CLS Speaks for tonight. I am very excited about this presentation and very excited to have Dr. Ferdinand with us. I am Jan McAlister. I am the president of the Southeast Lipid Association and have really come to appreciate the CLS Speaks webinars that we have been doing. If you have to get off the call, remember this is being recorded and you do have access to it along with other continuing education items at the National Lipid Association website. So you can log on and listen to what you missed in this presentation and possibly find some other presentations that you were not a part of. So without further ado, I'm going to introduce Dr. Ferdinand, who anyone who's been a part of the National Lipid Association knows that Dr. Ferdinand has been an active member for quite some time. He is a professor of medicine, the Gerald S. Berenson Endowed Chair in Preventive Cardiology at the Tulane University School of Medicine, and previously professor of clinical pharmacology at Xavier University, New Orleans. Clinical professor of medicine at Emory University and here in Atlanta. Dr. Ferdinand received his medical degree from Howard University College of Medicine in Washington, D.C. He is board certified in internal medicine and cardiovascular disease, certified in the subspecialty of nuclear cardiology, and a specialist in clinical hypertension. He is a member of the Association of University Cardiologists, past chair of the National Forum for Heart Disease and Stroke Prevention, and prior chief science officer and chair of the Association of Black Cardiologists. He is presently on the board of the Partnership to Advance Cardiovascular Health, National Lipid Association, and the American Society of Preventive Cardiology. During his presentation, you are able to put questions in the chat session. He will have a time at the end of the presentation for us to go over questions, or you can unmute yourself and ask your own question. So without further ado, Dr. Ferdinand, I'm going to hand it over to you.
Thank you so much for this opportunity. I know it's an area of interest. We're going to discuss lipoprotein little a and ASCVD. And I'm going to answer the question, is it time for universal screening? Here are my disclosures. So first, we'll talk about the role of lipoprotein A and ASCVD. I'll explore which of the tests are best, the milligrams or the nanomoles. We'll look at the lipoprotein little a emerging research. And I know there's a lot of interest because now we're getting agents which are on the horizon. And then I'll answer the question, which is what we had in our title, should we achieve universal LP little a testing? Well, let's start with the case. I think it's always good to have a realistic view of how any discussion is going to be centered. This is a real patient. I've changed the name. She allows me to use her case otherwise. She's a 47-year-old white female. She was referred to our clinic because of new onset chest pain. She had recently gone to the emergency department because she was having recurrent new onset chest tightness. Her resting ECG showed only non-specific changes. Troponins were negative ×3. And as you know, many younger females are often told that you're having anxiety, so she was sent home with the diagnosis of a possible anxiety attack. She really didn't have any prior cardiac disease. Her blood pressure has been well controlled, and her chest discomfort, which she had noted at the time of going to the emergency room, now was occurring with minimal activity. So if you took a look at her, you would think that she's very healthy, but she does have a positive family history. Her mother had coronary bypass at the age of 62, which is premature for a woman. And as a hospital nurse, she has good health habits. She exercises. She has a fairly fastidious diet. She drinks occasionally, but doesn't smoke or use any illicit drugs. And her physical exam was unremarkable. Here's her lipid profile. It's really very average, a little bit less than average, the LDL of 108. Blood pressure is normal. She did not have diabetes. Remember, she exercises vigorously and is not overweight. Her A1C is normal at 5.4. Because of a ASCVD risk that was very low, you would think that there's nothing else to do, but she convinced me that something was going on. So she underwent a nuclear stress test, and indeed it was positive in the area of the anterior wall. This is what we found on subsequent angiogram, and 95% very proximal left anterior descending. And the test that we did that really pushed us to do more was a markedly elevated lipoprotein A, 227 nanomoles per liter. And remember, this should be less than 75. So this is almost 3 times normal. Let's start with looking at this pastry. I don't know how many of you will become hungry looking at this, but this is called a Danish kringle. And when you cut it, it has this little flattened appearance to it. The reason this is important because one of the unique aspects of this LDL-like moiety is the presence of an apple lipoprotein little a, and it forms these little protein structures that are called kringles. This distinguishes it from the LDL, and the presence of the apple lipoprotein A increases the risk of getting atherosclerotic disease when it's elevated. It does have an ApoB, so it does have that particular component similar to the conventional LDL, but it's those repeating kringles that makes this an unusual moiety. Another thing that's a little bit unusual is that it has an area on kringle 410 where the oxidized phospholipids attach very easily. And we know those will increase the chances of the LDL-like substance being taken up by the macrophages, causing a foam shell, and may actually increase the risk of having atherosclerosis. Now, is this something that's just a fad? Do we have evidence that lipoprotein A is indeed causal for atherosclerotic cardiovascular disease? The answer is yes. Epidemiologic studies suggest that, but when we do genome-wide associations, those persons who have the elevated LPA gene, and in Mendelian randomization studies, when compared to those persons who do not have the SNPs at the LPA gene, those persons who have that genotype have clearly a higher risk for acute myocardial infarction, overall cardiovascular disease, stroke, ischemic stroke, not hemorrhagic stroke, peripheral arterial disease. There's even some data to suggest it may increase the risk for heart failure and calcified aortic valve stenosis and overall mortality. So what's a normal? Well, if you look at the curve, most people have a normal lipoprotein A less than 30. The cutoff of 50 is somewhat arbitrary, but if you take the cutoff at 50 milligrams per deciliter, now you're looking at anywhere from 20 to 25% of persons will be seen to have an elevated lipoprotein little a. Now remember, FH is also a cause of a genetic form of hypolipidemia that will cause atherosclerosis, but even at its best estimates, it's only 1 out of 200, 1 out of 250. Here you're talking about 20% of the population may have an elevated lipoprotein little a. So it's the most common genetic form of hypercholesterolemia. And based on those studies that we've already discussed, it is causal for an increase in cardiovascular disease and atherosclerosis. The majority of people, therefore, have a normal level, but about 25% will have an elevated level. This is some of the data. I'm not going to go through all of the base data that leads to our conclusion that it's causal, but this is one study that looked at a cohort of multiple studies, 9,000 patients, And you can see when you get a milligrams per deciliter level of about 50, there's a significant increase in the risk after adjustment for age and sex for non-fatal MI and coronary death. We underestimate the risk in women. We underestimate the risk of family history. This analysis done in JACC looked at family history. The reason it's not part of our pooled cohort is not because it's not important, but originally, when the Framingham analysis was done in 1948, it was really difficult to make head or tails of the family history because the case report forms were so poor in terms of documenting. The Framingham offspring does suggest family history is a risk. And the Reynolds calculation, I think most of you have heard of that, which uses family history and CRP, seems to be a better predictor in women than even the pooled cohort. Taking that into account, if you take family history, a detailed family history, and you increase the use of LPA as a causal factor, you can see they're additive and get a significant increase in the risk for atherosclerotic cardiovascular disease. Remember, the young lady that we eventually intervened on was only 47 years of age, normal body weight, non-hypertensive. Conventional LDL levels were even less than the average, did not have diabetes, did not smoke or use illicit drugs. So family history, LPA, even in people who would be conventionally deemed as low risk, can show an improved discrimination and actually reclassify those patients as having significant risk. I'm going to bring your attention to 2 or 3 papers that I think are seminal, that are newer, and give us a lot of information on where we may be going in the future. This is one, a scientific statement from the American Heart Association. It was published late in 2022. The first author is Jeanette Reyes-Sofer, and it is a very detailed overview of lipoprotein A, a genetically determined causal and prevalent. Causal because it directly relates to atherosclerotic cardiovascular disease, prevalent because it is present in anywhere from 20 to 25% of the population. Causal and prevalent risk factor, a scientific statement from the American Heart Association. Here's the central illustration from our particular working group. And you see again those ApoA attached to an LDL, giving an increased risk for atherosclerosis, thrombosis, and calcification on the aortic valve. And some of the unique aspects we'll discuss very shortly, the genetics, ethnicity, and race, associated medical conditions, and environment. Of all of those things, genetics really is the main driver. It does vary across race, ethnicity. There are medical conditions that can affect it, and I'll discuss that in a minute or so. Environment, not so much. It's important that we all continue to have appropriate physical activity, that we continue to avoid smoke, that low saturated cholesterol diet may be beneficial for LDL cholesterol, but those hygienic measures don't really have much of an impact on lipoprotein A. So we talked in my introduction, I said we're going to discuss how to measure it. There are 2 ways. One way is the nanomoles per liter. Now, this is somewhat of an advanced way of measuring it. You have to check with your lab and see how they report it. The case that I reported had nanomoles per liter. It was a better way of measuring than the older conventional way of milligrams. Nanomoles is the number of particles. It's unaffected by the heterogeneity of the LPA repeating kringles, and it can be calibrated based on the WHO, whereas the milligrams per deciliter takes into account the entire lipoprotein A, and it is affected by the number of repeats that you have in the kringle type 4-2. So what should you do? Well, know what your lab is. If your lab is using milligrams per deciliter, then the cut point is conventionally considered to be at 50 milligrams per deciliter. But if you can get a lab that reports it in nanomoles, it's going to be a probably better measurement of the impact of lipoprotein A. And the cut point for that is more similar to 125 nanomoles per liter. Now, if you can do the math, it's about 2.5 times. my biochemist friends really don't like that idea of trying to exchange milligrams for nanomoles. But there is some suggestion that if your lab is giving you milligrams, you can convert it to nanomoles by going 2.5. I think it's more important for us to understand that if a patient gets a test in milligrams and then subsequently, for some reason, goes to another clinician and gets a test and comes back in nanomoles, before it may have been 50 or 60 and now it's 125, 150, it doesn't mean that their lipoprotein A has suddenly doubled or tripled. There is a code. For many years, those of us who have been working in this field struggled to get it with an ICD, and it's now an ICD-10 code. This is the code. You can even put it in for elevated lipoprotein A if you have some idea that the patient already has it. Or if they have a family history of premature disease, you could almost assume that elevated lipoprotein A may be present. And there is reimbursement that's available if you put it in for a lab code. Now, I talked about how it's affected. 70 to even greater than 90% of the chances, it's affected by the LPA gene. That's LP big A. That's the name of the gene that's on chromosome 6 that causes some of the variants, the SNPs, and that elevates your lipoprotein A. So it's genetic. It starts maybe around 4 or 5, at least by 6 years of age. And if you look at the levels, they say pretty steady for the remaining part of the person's life. So if you're going to do universal screening, you could easily start in the pediatric age and get an idea of what a person's lipoprotein A level is going to be for the rest of his or her life. I'm going to make a nuance on that when we talk about women in a second. Non-genetic factors, we don't know how lipoprotein A is uptake by the body or how it's excreted, but it does appear to have some effect with severe CKD, decrease in GFR, severe proteinuria. Those persons will have an elevation of lipoprotein A, so you should take that into account. It is made in the liver, so persons with significant liver disease will have a decrease in lipoprotein A, and it does appear to be affected by hormones with hypothyroidism, pregnancy, and hormone replacement. Now, that's not therapeutic. This is observational, but those are things that we would take into account if we were measuring it. And as I mentioned before, lifestyle changes are important for overall good health, but the low saturated fat diet, physical activity has little impact on lipoprotein A. I was pleased to be part of a National Heart, Lung, and Blood Institute working group many years ago. The first author is Sam Samikas. He's from San Diego. He's been the luminary that's been pushing for us to measure lipoprotein A, and now he's leading some of the efforts with research on how we may be able to intervene in those persons who have this common cause of atherosclerosis, which it really was first recognized in 1963 by a geneticist named Berg, but only now in the late 2000s are we really starting to pay attention to lipoprotein A. One of the things that we noted in our working group report is that we know that to a large extent there is no real difference among so-called races. It's not a genetic or a biologic category. But if you look at continents of ancestry, of groupings of persons, there appears to be higher levels of lipoprotein A in persons of African descent, and so you see it in African Americans, and South Asian descent. And some of the considerations is that this may be a gene that started in the area of ancestral Africa, and then later when clients moved out to South Asia, you had an increase in lipoprotein A in that population. Somewhat less in East Asia, and when populations migrated to North America, the population then is going to be a mixture, but the areas where it really is high, and those would be regions of ancestry in Africa and South Asia. Here's a cartoon that kind of summarizes the biology. ApoA is synthesized in the liver, hence lower levels in patients who have severe liver disease. It is then excreted, deposits across the vasculature and on the aortic valve, coronaries, the peripheral arteries, the carotids, We're not really sure exactly, there's no consensus of how it is then taken up, although it does appear to have some excretion in the kidneys, hence patients with severe CKD may have elevated lipoprotein A. All right, let's talk about some populations. I'm not going to call women a special population because it's men who are special. There are actually more women than men. And if you look at age as a risk, there are probably more women with heart disease than men. So I'm not going to say special populations, I'm just going to focus on some of these populations. Women, South Asians, and African Americans. Let's first look at women. We know that we underestimate the burden of cardiovascular disease in women. And one of the hallmarks that we may not have been paying attention to is the presence of lipoprotein A, which overrides the benefit of being a premenopausal female. This report from Paul Ricker and his group, published in JACC, looked at two of the main studies in which we get a lot of our epidemiologic data in women: the Women's Health Study, the Women's Health Initiative, and the Jupiter study, which was an interventional study with rosuvastatin versus placebo, but it had a large cohort of women. And in all of these studies, going back to the milligrams per deciliter, which is the older way in which we were measuring lipoprotein A, at 50 milligrams deciliter or higher, the risk was clearly higher in women. So especially in women, if you have a suspicion because of premature disease in the family, lipoprotein A may be one of the best means of increasing sensitivity to the risk for atherosclerosis, finding this causal agent, and not just doing the conventional cohort study pooled risk calculator, which is not going to include lipoprotein A. In terms of the changes, I mentioned and hinted at this before, it does appear to come down with pregnancy and hormone replacement, and it goes up at the time of menopause. So although lipoprotein A is genetically driven, and although it keeps its same level for the most part throughout most of the life, you may see an uptick in women once they get in the postmenopausal age. And this may be indeed another reason why we see the increase in risk in women, such that being a female and having the protective effect of being female is essentially lost after menopause, 4 to 5 years after menopause. This is from Copenhagen. The Scandinavian countries do a wonderful job of making these type of observations because they have a uniform health system and they're able to get records on everyone, and looked at 37,000 plus women, 32,000 plus men. And if you look at the forest plot, you see that the risk for myocardial infarction, ischemic heart disease, the trend towards ischemic stroke, the clear relationship to aortic valve disease, the trend towards heart failure, cardiovascular mortality is as similar, no interaction by sex in men and in women. So in your female patients, you may be able to get a better assessment of risk, especially those who are 50 years and older, by measuring lipoprotein A. In the African American population, which is a mixed population, it's heterogeneous, but to a large extent, the African ancestry has an increase in the LPA gene. Now, that's not LP little a, that's LP big A. That's the gene on chromosome 6 that is related to the levels of lipoprotein A. And as a continent of ancestry, it appears to have an increased risk for LPA. Let's look at some epidemiologic data to support that. This is the MESA trial. It's an NIH study, looked at Black adults, white adults, Chinese American, and Hispanic adults, large cohort. And when you look across the population, it's easy to see that indeed the levels of lipoprotein A are 2 plus greater than that seen in the other populations, again, indicating that increased risk that may be associated with continent of ancestry. One thing I like to bring home is that LDLs are really not higher in African Americans, and the HDL is usually well preserved. The triglycerides are a little bit lower. So the conventional lipid profile is going to miss this additional risk in that population. This is an editorial that I did in JACC. I was commenting on a study that suggested that HDL really did not predict either having high HDL as being beneficial or low HDL as a risk. did not really predict risk in the African American population. This central illustration suggests the following. If you really want to look at risk, don't forget the social determinants of health, where people work, live, play, and pray. Pay attention to the conventional risk factors. Hypertension is the most prevalent of all the risk factors, especially in the Black population. Consider coronary calcium score, which appears to be beneficial as a risk predictor, regardless of race or ethnicity. And consider elevated lipoprotein A. On the scale, those are the things that really weigh down risk in the Black population. The things where I didn't put a lot of weight on is simply looking at a person's skin color or self-identified race, thinking that you have genetic factors when you really haven't measured them, and putting too much emphasis on HDL, person who has a fairly robust HDL, strong family history, uncontrolled risk factors, and telling them, well, your HDL is high, I think you're protected. There's no evidence really to support that. All right, let's talk about the studies. What's the future going to hold? Well, first of all, we really don't know. If we look at the conventional, presently available approaches, statins may actually increase LPA. That doesn't mean you don't use statins. The data on statins is so robust and so persistent that it decreases risk in those patients who have elevated risk. Statins have to be the bedrock of pharmacotherapy. Niacin, well, it decreases LPA, but there's been no study to show a benefit with niacin. PCSK9s robustly lower LDL cholesterol, even on top of high-intensity statins, but they have a bonus of decreasing LPA. Now, it's not necessarily enough to say that that is a predictive benefit of being on a PCSK9 inhibitor by itself, but when you look at the outcome studies, those persons who had higher LPAs did appear to have even a greater benefit with PCSK9 inhibition. So it's an added bonus, the main driver being the decrease in LDL, but it may also affect lipoprotein A. How much? Anywhere from 14 to 35%, depending on the individual. And in certain special centers and in Europe, especially Germany, there is the benefit of LPA apheresis, in which you can remove LPA, and observational data, not randomized clinical trials, but observational data looking at patients who have their LPA removed, they appear to have a significant benefit. So let's talk about what's coming on the horizon. Well, there are two approaches, both of which are based on attacking the genes that cause the elevated lipoprotein A. One is an antisense oligonucleotide. It's the one that's furthest along. It actually binds to the messenger RNA and forms nonsense so that the cell cannot make lipoprotein A. The other approach is the siRNA. It silences the making of the lipoprotein A by binding to something called the RISC complex. It causes an antisense strain, and then the mRNA no longer can function. So somewhat similar approaches, both of those looking at the manufacturing of lipoprotein A within the liver. Looking at these approaches in the phase 2 studies, they appear to be very, very robust in their ability to lower LPA. I'm going to show you the phase 2 very quickly, and then we'll go on to some more advanced studies using these agents. But one of the reasons I want to show you this phase 2 study is because the antisense oligonucleotide, which is the one that's furthest along, appears to be very beneficial in its ability to lower LPA. But one of the unfortunate components, if you look at female sex, markedly underrepresented, depending on the cohort and the group, as much as 60, 70% of the patients were male. And then in terms of race, ethnicity, we talked about South Asians, we talked about people of African descent, not represented in the phase 2 studies. The other one is the silencer, siRNA. It's called olpasiran. Again, very beneficial in terms of lowering it, a little bit better in terms of male sex, but not as many females as you really need, but again, predominantly white population. If you look at the Black population, very underrepresented. So we need to do better when these agents get finished with their phase 3 studies. hopefully they're going to have better representation than these phase 2 studies. All right, so let's look at the clinical trials now that are being designed for outcomes. None of them are available, but they're on the horizon, so we're going to discuss them. With the antisense, it's called pelacarsen. The trial is the Horizon LPA trial. It has already been enrolled. The phase 2 data indicates it lowers LPA anywhere from 80 to 90, up to 92%. This is the one that's in the Horizon study, and we may have some answers on this one in the next 1 to 2 years. The siRNA, which is further along, is olpasiran. It tends to be a little bit more robust than even the ASO. It's started their phase 3 study. It's called Ocean A. The pelacarsen is Horizon. The siRNA with olpasiran is Ocean. It reduces the LPA as much as 98%, and there are two others that are a little bit further behind. They also have been shown to have a robust reduction in the LPA levels. There is an oral lipoprotein A, just got into phase 1. It appears to be working. Needs a lot more work, and they are going to look at the future of having an outcome study with high-risk patients. And there's even some preliminary evidence that they may be able to do CRISPR gene editing to block the formation of lipoprotein A. So let's look at the studies, what we have that's closest to perhaps being available at some time in the future. The one that's closest is Horizon. In its inclusion criteria, these are patients who have definite ASCVD. So this is going to be secondary prevention. They have a history of MI, history of stroke, peripheral arterial disease. The cut point, 175 nanomoles per liter, which is high. Remember, we said that the arbitrary cut point was 50 milligrams per deciliter or 125 nanomoles. And the primary outcome is going to be major MACE. So that's the Horizon study using the ASO pelacarsen. Ocean A is the siRNA. It also is a secondary. It also is high-risk patients, but it takes a little bit more liberty, including patients in the blue circle who have had PCI and other risk factors. They're using a higher cut point for their LPA value of 200 nanomoles per liter. Primary prevention, probably won't see a study with that. It's hard to do a primary prevention study because of the large numbers of patients that would need to be included. And we're going to first see how these secondary prevention studies manifest themselves in outcomes before tackling any primary prevention studies. This is the cohort. It's already enrolled, 8,000 patients. It's given sub-Q every month. Don't know when it's going to be available. This is an early estimate of mid-2024. I don't think it's going to make that. It's probably not going to read out until 2025. In the meantime, I'll make some comments in a few minutes what we should do with LPA while we are waiting the results of Horizon. So let's now talk about taking what we have discussed. We looked at the biology, pathophysiology, the genetics that underpin lipoprotein A, the approaches, some unique aspects across women, patients of African descent, and South Asians. So what should we do now? Well, one of the things is we need to understand that it is causal for atherosclerosis. It is a marker for an increase in risk. And it's like these young men, you see them in Atlanta. This is New Orleans, but you see it in Atlanta. They'll come zooming past you doing tricks on their bikes. They feel great. They're very high risk. So LPA does give us a new tool to determine a causal factor for atherosclerosis, regardless whether or not the patient has manifested symptomatic disease. The guideline from 2018 really didn't say anything about screening. They say it was a risk-enhancing feature. I think it somewhat underplays the power of LPA. They did embrace the threshold of 50 milligrams per deciliter. The Europeans, a little bit ahead of the time, and the Canadians also a little bit more forward-thinking. They suggest screening for all adults, both in the European guidelines and the thresholds. And they even suggest for primary prevention, 180 milligrams, which is markedly higher than 50, is a risk factor. The National Lipid Association's paper came out in 2022. It's not a full guideline, it's a scientific statement, but it's pretty strong in its recommendations. Don Wilson, the first author, and they suggest that it is reasonable to define risk for ASCVD by measuring LPA. And who are those persons? If you have a first-degree relative with premature disease, less than 55 for a man, 65 for a woman. Remember the case we had, the young, thin nurse who didn't smoke, exercise, had normal lipids, normal blood pressure, and was not diabetic. Her mother had bypassed at age 62. So you would have measured LPA, and in fact, we did. A personal history of premature ASCVD, the person who gets an event or develops disease early in life, 20, 30, 40 years of age. And patients who have FH, or the phenotype for FH, an LDL of 190 above, they tend to have higher LPAs. It may be as much as 30% of what we're calling the LDL cholesterol is actually lipoprotein A. It's reasonable. It may be reasonable if the person is in that intermediate group and you're trying to decide whether to treat them more intensively. If you have a person who you're placing on a statin and their LDL is just not moving the way you would like it to, it may be because of a higher proportion of lipoprotein A. And to cascade, if you do find a person who has elevated lipoprotein A, cascade screening would then be approached. I haven't been talking about calcified aortic valve stenosis, but that's another risk. The most recent paper comes from the European Atherosclerosis Society. They, again, the Europeans are pretty consistent. Check LPA in everybody, cascade if you need to. Once you get that high level, you double or more your risk of ASCVD, regardless of your calculated baseline risk. And this increase in cardiovascular events with an elevated LPA can be mitigated by lowering LDL cholesterol. So statins don't lower it, but statins lower LDL. So intensive reduction of the LDL will mitigate some of the risk of LPA. They suggest that this risk is present even if you have a low LDL. Remember the young lady, her LDL was less than average. That if you look at lipoprotein A, it even be more per particle of a risk causal factor than LDL itself. And even in children, there are some children who have ischemic strokes at a young age. Elevated lipoprotein A could be a marker. The European Atherosclerosis Society mentions this conversion factor, but I caution you, some of your biochemist colleagues are going to not say that's appropriate, but they do suggest that if it comes, a report comes back in milligrams per deciliter, you can multiply it by 2 times 5 to get nanomoles per liter. Final slides. If you really want to help your patients, you got to talk to them. This is something where you have to sit down, avoid a lot of jargon, use models, explain to the person what's going on so that they can understand, shared decision-making when you order this test, because right now we don't have a specific therapy for it. I like to give patients handouts. This is CardioSmart. ACC does a wonderful job with handouts. They have one on lipoprotein A, as does the PCNA. Again, very nice handouts, easy to read. What is lipoprotein A? They talk about the testing. Family Heart Foundation also has wonderful handouts. They also talk about understanding it and what to do if you have elevated lipoprotein A. Take home, LDL is still the main target, but LPA is independent, common, and causal. I think universal screening is the way to go to help predict ASCVD and guideline intensity of treatment. It's been around since 1963. We do have some new approaches with the sRNAs and the antisense oligonucleotides. They're not available for prime time. We're waiting to see the benefits from those studies, but in the meantime, knowing that patient's risk will help guide our intensity of approach. One last comment. When we get these new therapies, we need to make sure that they are applied equally, regardless of a person's race, ethnicity, sex, gender, geography, socioeconomic status, ability, or disability. Getting new drugs, new approaches, and not applying equally, we're going to miss the boat. Health equity is a moral and practical imperative. Thank you very much. We got a few minutes for questions.
Dr. Ferdinand, excellent, excellent presentation. I think you hit all of the spots that everyone has been asking about. I'm going to ask my own question while everybody is sending in their questions, because I get a lot of referrals into my clinic for elevated Lp(a), usually from primary care. So one of my biggest pet peeves is, if you don't know what to do with it, then why are you testing it? But then they test it and then they send the elevated numbers to me without even starting anything or talking to the patient. And then my second question is, or my second pet peeve is, they continue to recheck it. And I keep telling them, once you know they have elevated Lp(a), you don't need to keep rechecking it. Am I missing something, or am I on the right track?
Well, I think I hopefully made a fairly convincing argument that the reason you tested, even though these interventions with the ASO and the sRNAs are not available, the reason you tested it because it really gives you a better picture of a causal factor for atherosclerosis. The patient that I showed you is a real patient. And doing a pooled cohort evaluation and looking at her, she's thin and normal blood pressure, and telling her that it's anxiety and giving her a sedative, that's not the way to go. You need to go further. She had a premature family history. So that's the reason you test it. Then it may actually drive you to intensify your statin therapy, which doesn't lower LPA, but especially if the patient already has atherosclerosis, you can make a really great case for the PCSK9 inhibitors, which do lower LPA, not as potently as the ASO or the sRNAs, but it's going to drive you to use that PCSK9 a little bit earlier. Now, in terms of repeat testing, no, you don't have to do repeat testing. The change that I mentioned in postmenopausal women is indeed true. So if you have a woman who perhaps got an LPA tested years and years ago, and now she has gone through menopause, she's in her mid to late 50s, and her risk factors are intermediate, you're really not sure, maybe getting an LPA, see if it's going up substantially, may drive you to more intense intervention. But no, you don't really have to repeat it.
And you had just kind of mentioned something. Gosh, now I just forgot what I was going to ask you about.
I see one in the chat. It's on LPA apheresis. Yeah. We don't have it at Tulane. I don't know if they have it at Emory. I used to be at Emory. It is something that will remove it, but remember, it's being made by the liver, so you got to do it every 1 to 2 weeks, and it's pretty tough. You may have to put a PICC line in or have a port. It does work, but it's costly and it's somewhat intense. If these ASOs and the sRNAs come to pass, they'll be taking the place of doing apheresis. And I think if you have someone who has markedly elevated LPAs in the hundreds, premature atherosclerosis, I'd enter them into a study, and that'd be the way to go.
The second one in the chat is, without current treatment for Lp(a), you mentioned it's still risky even at low LDL levels.
Yeah, the Europeans mentioned that. It's in their statement.
So what is the threshold, the guidance of the threshold they should pursue for how aggressive you are to be with LDL lowering with ASCVD and Lp(a)?
Yeah. So in persons who have elevated lipoprotein(a), you put them into another risk class. So the conventional LDL less than 100. For the LDL, that person who is at high risk, less than 70. And with the consensus decision pathway, not the guideline, it didn't have this category of very high risk, less than 55. So if that person is, quote, normal, getting them less than 100 is no longer the case, because now with the LDL of 108, similar to that young lady, we want to drive her down less than 70. And because we saw such a horrendous lesion, I would drive her down less than 55. Or if the person had not had an angiogram, you don't really have that documentation. But let's say they have a coronary calcium score that's positive and they're over 70, I drive them down less than 70. So I think it increases the risk categorization for the person, and it gets you away from this idea that less than 100 is good enough. Less than 100 is because in the westernized, industrialized societies, that's average. But that's high. That's not normal. In the non-westernized, non-industrialized societies, rural China, rural Africa, the Amazonian Indians, they walk around with LDLs of 30 and 40. So it just makes sense that if a person has a lipoprotein A that's elevated, and even if they're less than average, it's still high, it still needs to be intensively approached.
How do you reconcile studies suggesting no additional risk with elevated Lp(a) in women unless they're hyperlipidemic, with other studies which seem to suggest Lp(a) risk is independent of ApoB and calculated LDL?
No, the Copenhagen study said that the risk was similar to women with elevated lipoprotein. I showed that one. And these were thousands of women, postmenopausal, so age becomes a factor. But a woman who has an elevated lipoprotein A who's postmenopausal, where you lose a lot of protective effect of being female, the lipoprotein A risk for a wide range of cardiovascular conditions was the same. And in a younger woman, going back to my case, she was premenopausal. A younger woman, if you have elevated lipoprotein A, even with a so-called low LDL, I still think it's a causal risk factor. I wouldn't hesitate to treat that person, get their LDL down to a lower risk category once you have elevated lipoprotein A. The guidelines are not going to tell us that because they're from 2018. They say it was a risk enhancer. But since 2018, we've just gotten so much data. And if you listen to the Canadians and the Europeans, and I do, we would measure it in everyone, and we would intensify our therapy, even if the LDL is so-called low.
So for our therapies that are to be coming in the future, it seems like all the research is in secondary prevention, but we all have primary prevention patients that are neurotic about these Lp(a) levels, and they're not going to be able to get approved for one of the newer medications because certainly it's probably going to be approved through the FDA for secondary prevention, not primary prevention.
Correct. So what I think you would do in that particular case is tell the person that, yes, you have this causal risk factor, if you want to call it a risk marker. What we're going to do is we're going to intensively treat your LDL. We're going to upregulate the class of risk you are with your LDL. We're going to treat the LDL. We're not going to try to put you on these medicines. We're not going to skirt the indication because you weren't in the study. Patients like you weren't in the study, and we just don't have any data on you. And I don't think that it would be reasonable to try to go around the indication just to use an ASO or an siRNA in a person who has not demonstrated the presence of disease as noted in the studies.
Well, there are no more questions in the chat. That sounds like a great question to end on and really a great summary of treating patients. So we appreciate your time on this Tuesday evening. Thank you very much for all of the information. And by all means, hope everybody stays dry. People are talking about how great the talk is. And once again, y'all can find the talk recorded at the National Lipid Association website. Everybody have a good night. Thanks again, Dr. Ferdinand.
All right, see ya.